Now let's move on to discussing the management of liver disease. First, we will talk about the pathophysiological mechanisms that link hyperuricemia and liver disease. Briefly, we will mention that hyperuricemia can contribute to the development of liver disease through three mechanisms such as oxidative stress, since uric acid acts as a pro-oxidant only within cells. This leads to an increase in the production of reactive oxygen species. It also promotes inflammation, either through the activation of inflammatory pathways such as MAP kinase or AKT, or by suppressing the AMPK pathway, thereby promoting inflammation and again oxidative stress. It also induces apoptosis through endoplasmic reticulum stress and mitochondrial damage. All of this ultimately contributes to lipogenesis in the liver, and it exacerbates the development of non-alcoholic fatty acid. In this image, we can see the different mechanisms we previously discussed and how uric acid acts by increasing free oxidative radicals and inflammation through various pathways, which ultimately leads to inflammasome activation and cellular apoptosis. Then I found the page at the top right, which is LiverTox, and it's available on PubMed. By typing LiverTox, a drop-down appears with all the drugs and whether they are associated with liver disorders, along with the mechanism by which they act on the liver. We'll start by talking about allopurinol. The recommendation for patients with liver disease who are going to use allopurinol is to reduce the dose, similar to what is recommended in cases of renal insufficiency. We will start with a dose of 50 or 100, but extending the duration of the drug's use. A liver function panel should be requested during the early stages of therapy. The expected clinical presentation of allopurinol toxicity involves minor and transient changes in liver function tests in 2 to 6% of patients, but there is a risk of liver injury in the context of DRESS syndrome, which can be induced by allopurinol. The prevalence is low, 1 in every 10,000 patients, and the mechanism by which it occurs is immunoallergic, which recent studies suggest may be related to or triggered by concurrent infections with the human herpes virus, type 6 cytomegalovirus, or the Epstein-Barr virus. And as a curiosity, in case anyone was wondering, HLA-B58 only significantly increases the risk of severe skin reactions, but it is not potentially involved in liver abnormalities. Regarding febuxostat, liver function tests should be requested before starting treatment and repeated periodically, but from then on, they are only recommended based on clinical judgment. That repetition refers to liver enzyme monitoring. The expected clinical presentation has not been observed in real-life settings, but a phase 3 study did detect mild abnormalities in liver function tests in 5% of patients treated with febuxostat. The mechanism is related to the drug's own metabolism, which is due to glucuronidation or metabolism via the cytochrome P450 system. Next, we talk about benzbromarone, which is contraindicated in cases of liver failure. As for the expected clinical presentation, there are few liver profile abnormalities occurring in about 0.1% of patients. However, there have been reported cases of severe hepatotoxicity, some of them with fatal outcomes, which is the reason why benzbromarone is contraindicated in patients with liver disease. The mechanism is due to its hepatic metabolism. Next, we talk, finally in this section, about colchicine, which is contraindicated in cases of severe liver failure. This contraindication is based solely on the drug's metabolism, since 50% of it undergoes hepatic metabolism by the cytochrome P450 and 450.